This slide isn't a formal poll, but it's just to get you thinking about what percentage of healthcare is actually provided by the formal healthcare system that we hear about on the media these days. Is it from 90, 70, 50, 25, or 5? You can probably guess that actually the formal healthcare system only provides somewhere between about 3 to 5% of care. Turns out that 90% of care is provided by family caregivers or in the form of self-care, but that's another talk. So that leaves 10% of formal care. Now, of that 10% of formal care, 70% of that is provided through the volunteer sector. Well, in our province of Alberta, we have about 1.4 million volunteers out of a population of 4.5 million, but we have over 26,000 not-for-profit volunteer and charitable organizations. Those are registered. So it doesn't include religious, community, school-based, or individual volunteering. 175,000 people employed in the volunteer sector and estimated to provide $9.6 billion of economic benefit. So why does the health system, so I represent the system, so why would the system be interested in working with the volunteer sector? So this slide can apply to any healthcare system in the world. And what it says is that there's a small proportion of people to whom a large proportion of costs are attributable. So we call it the 565, 5% of the population to whom 2/3 of healthcare costs are attributable. So who are these people? Well, we often think that they're the drug-addicted, schizophrenic, homeless street people, but in reality, they're not. It turns out that these people are either frail older people or older people with multiple chronic conditions. The next thing that happens then is the healthcare system will say, well, why do they cost so much? And it turns out the reason they cost so much is because they end up in hospital. They're the largest users of the hospital acute care system. So when we ask this question of why do they end up in hospital, this is where a fatal error occurs, because most health systems will give you a list of diseases, things like heart failure or chronic lung disease. And so in response to that, we set up more heart failure clinics, hire more cardiologists, and absolutely nothing changes. So one of the things we did is that we worked upstream to say, why did this person really end up in hospital? And what we heard was a totally different story. What we heard was, well, medically, maybe this person didn't need to be in hospital, but what? But I couldn't send them home. They weren't managing at home. I knew that if I sent them home, they'd be right back. So what we were hearing was that the resources needed to look after these people in the community either didn't exist, weren't known, or weren't coordinated. With 26,000 volunteer organizations, you can probably guess that the doesn't exist doesn't apply. It's really, we in the healthcare system aren't aware of them, and we're not integrated. So here's some actual data. We looked at hospitalization, which is the biggest driver of costs in our healthcare system by some of our 103 local areas. And you can imagine that in your local area, the greater the proportion of elderly people, the higher the hospitalization rate. Sort of makes sense. And we see that here, but the dots are all over the map in terms of age of the population and hospitalization. Instead, though, if we then look at the resource availability in those local geographic areas and the hospitalization rate, look at what we see is that the fewer the community resources, the higher the hospitalization rate. Much better predictor of hospitalization than the actual age of the population, showing the importance of community resources. So with medical administrative data, we've tried to predict hospitalization. Can we predict who's going to end up in hospital and therefore intervene? Turns out you cannot predict hospitalization with medical administrative data. But in reality, any family doctor can predict which of their patients is likely to end up in hospital in the next year. Any community-based chronic disease nurse, and in fact, any Meals on Wheels driver can predict who of their clients will likely end up in hospital in the next year. We have a colleague, Sharon Anderson, who works in care of the elderly, and we were fortunate to work with her to be able to combine social data with medical administrative data to try and predict hospitalization. And once we did that, all became clear. And of all of the social factors that were able to predict hospitalization, one really stood out, and that's this one. Turns out that we could predict hospitalization by looking at many social factors, but the strongest social predictor was actually loneliness. You can see here the UCLA loneliness score amongst seniors in Edmonton was the best predictor of hospitalization, way better than any medical predictor. So what does that mean? Do we treat loneliness by putting people in hospital or having them come to a clinic? Is that our treatment for loneliness? Or how do we actually address loneliness? Well, you can imagine we don't have a formal system for addressing loneliness. We can use the volunteer, not-for-profit charitable sector, including just individual relationship. So there are healthcare systems. There actually are some accountable care organizations in the United States who hire people to go out and visit some of their clients to address loneliness. So we could set up a whole other system of hiring people and having to go from the government to go out and address loneliness, or we could use existing structures such as volunteer groups, charitable groups, or even at individual level, having tea with your neighbor. So I want to talk about another example briefly, Drive Happiness. So at the beginning of COVID, Alberta Health Services had 14,000 people who volunteered for us. On day one of COVID, our powers that be told all of these 14,000 volunteers to stay at home, not to come in. What they didn't realize was with the law of unintended consequences, some of these people happened to be drivers who drove people to important appointments like cancer chemotherapy, radiation therapy, dialysis. And all of a sudden we had none of these drivers. So in Edmonton, the organization Drive Happiness stepped up and they started driving people. So Drive Happiness provides subsidized and low-cost driving to people in need. Turns out that if you actually survey seniors, you find out that the number one need that they list is actually transportation for a variety of purposes. And so Drive Happiness, by interactions that we had with them over COVID, where they really, really stepped up to the plate to help fill in this gap of transportation. And once we realized the importance of transportation, for example, up to 11% of specialist appointments are missed because of transportation issues. When we realized the importance of transportation and they realized their power, we've now been able to spread across the province to address transportation issues. And this is just by our back and forth interaction with Drive Happiness between the healthcare system and volunteer sector. And just finally, going back to 26,200 not-for-profit organizations in Alberta, that's 1 to 160 people in our population. We worked with the city of Fort McMurray, who I think you're familiar with, in northeastern Alberta, home of the oil sands, where they had 750 not-for-profit organizations. That's one organization for 90 people. So how on earth does the local health system work with so many organizations? Well, what we found out was that our principle was do provincially that which makes sense to do provincially, do local or zonally that which makes sense to do in zones or regions, and do locally that which makes sense to do zonally. And I've given some examples of how we work at all three of those levels. How do we as a health system work with the volunteer sector? Well, as you heard, one of the most important things is sharing a vision and sharing also current understanding. So knowing where we are, where we want to go, that has really been the key to enable us to work with the volunteer sector and for them to work with us. And then, of course, we need a mechanism for that cooperation, collaboration. So we have committees at the provincial, zonal, local levels to work with each other. But I'm going to translate actually the next bullet point of accountability to actually co-design between the system and the volunteer sector. For a healthcare system, we like to be in charge. We like to be, have that accountability to our CEO. We're in charge, we'll direct things. But turns out that feels very uncomfortable to give up power. But interestingly, when we give up power, we actually gain power. So we're accountable to each other, work with each other as equal partners, and we can do amazing things. So just in conclusion, we're grateful for our ability to work with the volunteer sector. They provide amazing services and resources. However, they're experiencing the same things as everyone in the world is in terms of shortage of volunteers, challenges with being able to hire the paid workforce in the volunteer sector, difficulty with scheduling challenges. People want to work when they want to work, just like employees these days. And sometimes we have to remember again that the volunteer groups that work with us voluntarily. So again, we want to be appreciative and kind to them for all of the care that they help us partner with. So thanks very much.